Learn how modern chemotherapy can help transform pancreatic cancer treatment. Hello, this professionally resourced evidence-based content is created by Saboor, fellowship-trained consultant surgeon, and if you or someone you care about has just been told they have locally advanced pancreatic cancer that can't be removed surgically, you're in the right place. I know hearing unresectable can feel devastating, like all options have closed. But here's what I want you to understand today. Unresectable doesn't always mean permanently inoperable. We're going to talk about conversion surgery, how aggressive chemotherapy can sometimes shrink tumors that were initially deemed too advanced for surgery, making an operation possible after all. By the end, you'll understand what makes pancreatic cancer locally advanced, how specific chemotherapy regimens work to downstage these tumors, the criteria surgeons use to reassess whether surgery has become an option, and what outcomes look like when this conversion happens. This is about hope grounded in evidence. Locally advanced pancreatic cancer means the tumor hasn't spread to distant organs like the liver or lungs, but it has grown into nearby critical blood vessels, particularly the superior mesenteric artery or celiac axis. These are the main arteries that supply blood to your intestines and other abdominal organs. When a tumor wraps more than 180 degrees around these vessels or encases them completely, surgeons can't safely remove it without catastrophic bleeding or cutting off blood supply to vital organs. This affects about 30 to 40% of people diagnosed with pancreatic cancer. You can see in this image how a stage 3 pancreatic cancer encroaches on important blood vessels. They're caught in this middle ground between clearly resectable and metastatic disease. This matters to you because, while traditionally these patients weren't offered surgery, modern chemotherapy has changed that equation for some people. See in the image how the tumor may impinge on important blood vessels. The major goal of pancreatic cancer surgery is achieving what we call an R0 resection. That means removing the tumor completely, with clear margins, no cancer cells at the edges. A margin-positive resection, where cancer cells remain, strongly predicts early recurrence and short survival. This image clarifies the concept. When a tumor is encasing the superior mesenteric artery more than 180 degrees, or involving the celiac axis, extensively attempting immediate surgery carries an extremely high risk of leaving cancer behind. Think of it this way. If you're building a house, you want a solid foundation. Incomplete cancer removal is like building on sand. The disease comes back quickly, and the trauma of major surgery may have cost precious time when effective chemotherapy could have been given. That's why the strategy shifted to treating these tumors first with chemotherapy. It allows for tumor to shrink away from vessels. It treats microscopic metastatic spread. It allows identifying of patients in whom the disease progresses rapidly and does not respond. The chemotherapy regimen that's transformed outcomes for locally advanced pancreatic cancer is called FOLFIRINOX. This is a combination of 4 drugs: folinic acid, fluorouracil, irinotecan, and oxaliplatin. In the landmark PRODIGE 4 trial, which studied patients with metastatic pancreatic cancer, FOLFIRINOX improved median survival from 6.8 months with standard gemcitabine alone to 11.1 months, and the response rate was 32% compared to just 9%. When researchers looked specifically at locally advanced disease, systematic reviews found that about 26% of patients receiving FOLFIRINOX subsequently underwent surgical resection, and of those who made it to surgery, 74% achieved that crucial R0 resection with clear margins. Let me put those numbers in context. Remember, these are patients who were initially told surgery wasn't possible. After FOLFIRINOX, roughly 1 in 4 became surgical candidates, and 3 out of 4 of those had complete tumor removal. That's the power of aggressive systemic therapy. Now, FOLFIRINOX isn't easy. Grade 3 or 4 side effects occurred more frequently than with single-agent chemotherapy. Neutropenia, meaning low white blood cells, affected 46% of patients, fatigue 23%, and sensory neuropathy 9%, with symptoms of tingling, etc. But here's what matters. Despite greater toxicity, patients on FOLFIRINOX actually reported better quality of life compared to those on gentler chemotherapy. Why? Because tumor control matters enormously for how you feel. The benefits clearly outweigh the side effects. If you are supporting someone through this, understand that FOLFIRINOX typically involves close supportive care, prophylactic medications to support white blood cell counts, frequent clinic visits for lab testing, intravenous fluids when needed, and careful management of common side effects like fatigue, nausea, diarrhea, and nerve tingling. Most centers use a modified dosing schedule that's better tolerated while maintaining effectiveness. This approach may reduce the side effects profile and maintains treatment efficacy. After 4 to 6 months of chemotherapy, the critical question becomes, has the tumor responded enough to make surgery feasible? This is where things get nuanced, and if you are worried about someone you love, this is important to understand. Surgeons perform a new CT scan to look for 3 key things. First, has the tumor shrunk away from those critical blood vessels? The definition of borderline resectable disease includes solid tumor contact with the superior mesenteric artery of 180 degrees or less, or involvement of the portal vein that's potentially reconstructible. If FOLFIRINOX has reduced vessel involvement to these levels or below, surgery might now be possible. Second, have distant metastases developed? This is crucial. Roughly 20% of patients will develop metastatic disease during chemotherapy, which means the cancer's biology was more aggressive than imaging initially suggested. For these patients, continued chemotherapy rather than surgery becomes the right path. Third, what's happening with the tumor marker CA19-9? When elevated, this tumor marker is indicative of response to chemotherapy. While CA19-9 alone is not used alone to make decisions, a persistently rising level, despite chemotherapy, suggests disease progression. Here's something that might surprise you. Radiologic response doesn't always correlate perfectly with what surgeons find during operation, particularly after FOLFIRINOX. Scar tissue and inflammation can make tumors look larger on scans than they actually are. This CT shows before and after, demonstrating chemotherapy efficacy. In this instance, the tumor actually shrank. That's why many expert centers offer surgical exploration to all patients without documented metastatic disease, who have completed neoadjuvant therapy and maintain good performance status. The surgical team evaluates resectability directly during the operation, rather than depending on the CT alone. Among locally advanced patients who underwent surgery after FOLFIRINOX, 55% achieved R0 resections, median overall survival was 18.7 months, and 5-year survival was 9.5%. Now, I know when you hear these numbers, it's natural to feel scared. 9.5% 5-year survival sounds low. But remember, these are patients who started with 0 surgical options. Without conversion therapy, median survival for locally advanced disease treated with chemotherapy alone is typically 9 to 15 months, with virtually no 5-year survivors. Additional data from MD Anderson Cancer Center showed that among patients receiving FOLFIRINOX for locally advanced disease, partial radiologic responses occurred in 19%, and these patients were more likely to proceed to pancreatectomy. If you're supporting someone through this treatment journey, here's what to understand about the timeline. Most patients receive several cycles of modified FOLFIRINOX over about 3 to 6 months, followed by restaging scans. If surgery becomes possible and is performed, many surgeons recommend completing a total of 6 months of systemic chemotherapy, including the preoperative period. Recovery from pancreatic surgery typically takes 6 to 8 weeks before someone feels back to baseline. Close follow-up is essential. Get evaluated at a high-volume pancreatic cancer center. The data I've discussed comes largely from specialized centers, with multidisciplinary teams, including medical oncologists, radiation oncologists, and experienced pancreatic surgeons. If you've been diagnosed with locally advanced disease, seek a second opinion at a center, performing at least 15 to 20 pancreatic resections yearly. This information may be available on the website of the center where you are being treated or national cancer data sites. Ensure comprehensive staging has been completed. This means a multiphasic CT scan of chest, abdomen, and pelvis, not just a standard cord. The multiphasic part is crucial, as it captures images at different times after contrast injection, showing vessel involvement more clearly. Request baseline CA19-9 tumor marker measurement if not already done, and ask that it be checked every 1 to 3 months during therapy. Rising levels may indicate progression even when scans look stable. If jaundice is present, address biliary drainage early. Delivery of chemotherapy like FOLFIRINOX requires bilirubin levels to normalize. This usually means placement of a biliary stent. If your yellow and chemotherapy is planned, this needs attention within days, not weeks. Initiate early palliative care consultation. I know this phrase sounds frightening, but palliative care isn't about giving up. It's about comprehensive symptom management, pain control, and support throughout treatment. Multiple studies show that early palliative care improves quality of life and may actually extend survival in pancreatic cancer. Am I a candidate for FOLFIRINOX or modified FOLFIRINOX? This regimen requires good performance status. Essentially, you need to be active, able to care for yourself, and up and about more than 50% of waking hours. Age alone isn't a barrier, but overall fitness is. What specific criteria will you use to reassess resectability after chemotherapy? Understanding what your team is looking for. Degree of vessel involvement CA19-9 trends, absence of metastases helps you understand the goals. If imaging after chemotherapy shows I might be a surgical candidate, what is your center's approach? Some centers rely heavily on post-treatment imaging, while others routinely offer surgical exploration if no metastases have developed, recognizing that scans may not perfectly predict resectability. Should genetic testing be performed on my tumor? About 5 to 10% of pancreatic cancers are associated with inherited mutations in genes like BRCA2, PALB2, or ATM. This information can guide treatment choices and has implications for family members. What supportive care will be in place during FOLFIRINOX? Confirm the plan for growth factor support to protect white blood cells, anti-nausea medications, management of diarrhea, and monitoring for neuropathy. New or worsening abdominal pain that isn't controlled by current medications. Pancreatic cancer pain can be neuropathic due to tumor proximity to nerve plexuses. Additional interventions beyond standard pain medications may be needed. Fever above 100.4 degrees Fahrenheit 38 degrees Celsius while on chemotherapy, especially FOLFIRINOX. This could indicate neutropenic fever, low white blood cell counts with infection, which requires immediate medical attention. Sudden leg swelling, chest pain, or shortness of breath. Pancreatic cancer carries a 4 to 7 times higher risk of blood clots than other cancers. These symptoms could indicate deep vein thrombosis or pulmonary embolism. Persistent vomiting, inability to keep food or liquids down, or severe diarrhea lasting more than 24 hours while on chemotherapy. These require prompt intervention to prevent dehydration and electrolyte disturbances. Worsening jaundice or very dark urine despite a biliary stent. This might indicate stent malfunction requiring replacement. Locally advanced pancreatic cancer means tumor involvement of critical blood vessels that initially prevents safe surgical removal, but aggressive chemotherapy, particularly FOLFIRINOX, can shrink these tumors enough to make surgery possible in about 1 in 4 patients. Your next step: seek evaluation at a specialized pancreatic cancer center with multidisciplinary expertise in conversion surgery strategies. This information is for education. Always discuss your individual situation with your healthcare provider. I have outlined several reputable resources here which you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.